Treating psychiatric concomitant disease, you always have to remember this. I talked about it already, that we use these antipsychotics, not just for pain, but also to treat someone if they're bipolar, schizophrenic, delusional disorder, any other psychotic disorder. And I talked about the thymoleptics, which are the anti-epileptics. Those are a good class of meds. Antidepressants, I don't know. They're mood elevators. They're not really antidepressants. The thymoleptics are more antidepressants. And obviously psychiatric hospitalization, when we are pulling our hair out and don't know what else to do, we have these residential treatment centers, and you get these mixed patients who are kind of dual diagnosis with their pain syndrome and their psychiatric problems, and their addiction problems. Opioid dependence, I think I mentioned that. So we do treat this if this happens. Now, let me ask you, if you're 93 years old, and you're addicted to opioids, and you have pancreatic cancer, do I want to get that person off opioids? No. Seems kind of logical, doesn't it? It isn't, though, when you get out there and you deal with hospice. But yeah, I wouldn't be worried too much. And other countries, like in England, when you're terminal, they give you heroin. The doctor comes and injects you. So, and that doesn't seem right to our American minds because we're so prejudiced against these drugs. So like I said, you've got to find the balance. Because you can be prejudiced against these drugs and not want to give them to your patients, but if you're a doctor, you're going to get sued for not giving them. So that's the dilemma. If addiction starts to be the issue and you've got a nice young person, then treat with AA, Suboxone, Antabuse, Revia, psychotherapy. I like Revia, which is naltrexone, which is a narcotic antagonist. The only caveat there is if you're taking a narcotic, you don't want to take Revia, it'll kill you. But if you're off your narcotics and you take Revia, then when you try to use narcotics, they won't work. So obviously you want to make sure you're dealing with an addict and not someone who has pain because you've just gotten rid of their pain relief. That's the other thing. In reality, you've got so many narcotic exposures that'll work, and after a while, narcotics will stop working for you. So save them for when you need them. Remember that a lot of these addicts are not typical addicts. We created them. We have a word for it. We call it iatrogenic. It's a fancy word for the doctors didn't give enough care and figure it out enough, so we screwed up. Now we got to deal with it, but it's their fault. No, it isn't. It's ours. The behavioral health department insurance laws differ. In this case, you pay a full fee out of pocket, $120 an hour, yeah, right? We may not disclose personal and treatment information to others unless we feel it necessary to assure safety or payment. We maintain this confidentiality unless it suits us to do otherwise. Later, distress and angry at events beyond control. So that's what therapy sometimes feels like when you start, even though it's supposed to be something good. I think that's it. I'm done. So since I'm not getting direction, that means I'll take questions. So someone lowers the boom or pulls me off of here. Yes, sir.
I'm not sure if I'm completely correct, but I was interning at a couple of emergency rooms this summer, and they mentioned that pain is now a sixth vital. That if the patient comes in with pain, they have to be treated under law. Is that correct?
Well, the lawsuits involved are ones I tried to explain to you. And it's not that there's a specific law that they have to be treated. There's a specific remedy in the law. If you're undertreated, that's not good. And if you're overtreated, you get sued for either one. So you're between a rock and a hard place. So you have to try to do this treatment approach and try to get people on the right course. Some people, like I have a lady who's anxiolytic and she has shoulder pain, but she certainly has addiction issues too. So I'm not upset when we are, she'll call me up and say, they didn't give me a narcotic. And I go, well, yeah, I understand. You need to go to your pain doctor because they're not used to you and you look like you're drug seeking even though you've got lots and lots of pain. And you've got a history and you've got a daughter and a son who do drugs. So, but, eventually she did the team approach and I talked to her doctors and I'm doing her anxiolytic meds and she got more pain treatment because she took a team approach. And that's probably not really the answer you're looking for, but you're not going to get arrested if you don't give someone a narcotic.
Okay.
Go ahead.
Sorry.
Oh, well, Go ahead.
So I was curious how you mentioned allotted. At least I saw a lot of allotted addictions. I was wondering if there's a way where you can tell if a patient really has pain, either emotional, how you were saying, after your pain or your pain is gone, how reverberating pain.
If you have this entire model in your brain and you connect to that person like the Matrix, then you could tell.
So I would,
Well, I mean, you make your best guess, right? But the answer to your question is you have to have an internal neuron connection with their brain and your brain. It sounds funny now, but I'm sure we'll be doing it before the end of this century.
Hi. You would say that capsaicin as something that blocks chemical responses to pain?
It does, yes.
If I remember correctly from a neurobiology class I took, I think capsaicin is a chemical that activates neural responses to spicy food.
It is spice,
Okay.
and it's measured in Schofields.
Okay. Well, does that mean that you can eat spicy foods and block your...
Well, you got to remember, you're going to get. I used to do that. I used to eat habaneros every day, and the GI guy told me I didn't get Crohn-looking disease from habaneros, and the pathologist said my stomach was normal. And it turned out when I stopped habaneros, it went away. So you have to be careful, but it is true that if you have pain somewhere on your skin and you rub something hot on it, you won't feel the pain anymore. You might feel the hot pain, but you won't feel that pain anymore. So there is some blocking. It's kind of like the game theory. And like we were talking about up there before, game theory works to a degree, but then after a while you get in trouble again. I tried to point that out. But that's exactly what I was talking about. That's why I considered it the way I did. Yes, sir.
I know you mentioned Theta.
I'm sorry?
Theta.
Revenue.
Is it the same as morphine?
Yeah, naltrexone. Yeah. It is the same. That was it? Okay. The only thing I could mention more about that is there's an injection called Vivitrol, which gives you a little bit of Narcan or naltrexone over time, a little bit at a time. And I think the chemical in Narcan and naltrexone may be slightly different, but they're the same kind of drug. Next? Yes? No? All right, well, if that's it for questions, thank you very much.
Thank you, Dr. Soldinger. I want to thank you on behalf of myself and the rest of the members of California Theta Phi Delta Epsilon here at CSUN. And we wanted to present you with this plaque from the chapter, with special thanks from our chair of the Gelfand Lecture Committee, Lynette Nalbandian, the co-chair, Gabriela DeSilis. I always mix up your last name. And all the members from the Gelfand Lecture Committee, and of course the members of Phi Delta Epsilon. Thank you again, and we hope you enjoyed the lecture as much as we did.